The Nurse Theorist's Excellence in Action. In this edition, we feature Dorothea Orem's self-care deficit theory of nursing.
The foundational work leading to the development of self-care deficit nursing theory that describes and explains nursing began in 1958. At an earlier time, I had worked with nurses in general hospitals in a Midwestern state, and I became aware that they were unable to describe to others what they did as nurses. Their practice was to identify procedures they performed for nurses and also to use the word nursing in describing their work. My interpretation was that they did not have insights about the observations to be made and the cognitional work that is involved in nursing practice. My efforts to formalize a concept of what nursing was led by my desire to lay out the domain and boundaries of nursing as a field of knowledge and as a field of practice. I knew that the domain that is nursing would include human elements, human conditions, and human factors. I wanted to develop insights about these. The result I sought was understanding of the human constants and the variables of nursing practice, without which nursing could not be supported as a social institution. The central idea of the self-care deficit theory of nursing resulted from my exploration of the question, why do people need nursing? And the answer that I became aware of through my explorations is that people require nursing when they are unable to provide for themselves or dependent others the amount and quality of care that is necessary to maintain health and well-being. But these limitations come from the health situation in which the person is or the dependent other is. So nursing may be required when there are limitations, action limitations that prevent an individual for providing care for self or for dependents, care of a quality and quantity that is essential to maintain life and health. The health situation that sets up a requirement for nursing may be associated with a new developmental phase, such as motherhood, or with an acute or a chronic illness, with an injury, with a change in lifestyle, or with a new situation of living, a new environment.
The self-care deficit theory of nursing provides the structure for the cognitional work of nursing. Nurses need to think nursing as well as do nursing. And the structure that helps in the thinking of nursing is the nursing process. Within self-care deficit nursing theory, nursing process has 3 steps. The first is nursing diagnosis and prescription. The second is the design and planning of nursing systems. And the third is the production and management of nursing care.
Nursing diagnosis and prescription involves determining the patient's self-care deficit, which is established by relating the extent and nature of the therapeutic self-care demand, or self-care action requirements, to the patient's self-care capabilities, or capacity to do the work of self-care. There are 3 types of self-care requisites which regulate human development and function. Universal self-care requisites are associated with life processes and maintenance of human structure and function. Developmental self-care requisites are the special requisites associated with developmental stages of the life cycle. Health deviation self-care requisites are special requisites associated with acute or chronic illness, disabilities, and medical diagnostic and treatment procedures.
You haven't had any trouble since that other one, have you, with the tubing?
No, they've all been working fine.
Okay.
Basically, the only thing I had was...
I use a self-care deficit theory with clients like Terry to determine what the demand is made on him from the illness, such as HIV disease. And looking at his requisites, I see if he's meeting them or not, and if he's not, why not? And looking at the ability, his abilities, skills, and knowledge, and seeing why he's not meeting his requisites out of those 3 or 4 areas, and including motivation, will determine the direction my nursing care takes.
Designing and planning systems of nursing care involves identifying the human and technological factors required for nursing care and the ordering of actions of all persons in a way that will produce desired results. That is, knowing and meeting the therapeutic self-care demand and increasing development of or regulating exercise of self-care agency.
Okay, Henry, let's go and change your bag.
Okay.
When I first meet the client, I start planning my nursing care for this client, incorporating my nursing theory into it. I look at the basic conditioning factors. I look at the self-care deficit, self-care requisites, which is what can the patient do for themselves, and then I look at the self-care agency and see what the patient is capable of doing, and try to work with that. And then I'll try and see how can the self-care demands be reduced and how the self-care agency can be protected or enhanced. And I will first start by doing the total care myself and get the patient to observe, and then I will go on to plan on to doing some part myself and getting the patient to do some of the care, so involving him into it, and then I'll go on to getting him to do all his care and just supervising it until they're able to do total self-care.
Production and management of nursing systems occurs through various methods of assisting, including acting for or doing for the patient, guiding the patient, supporting the patient physically and psychologically, providing a developmental environment, and teaching the patient. The design of a nursing system is a function of the therapeutic self-care demand and self-care agency of the patient. When people are unable to take action to meet the demand, they require a wholly compensatory nursing system. In this nursing system, the nurse assists patients by doing or acting for them.
Hi, Hilda. How you doing? I'm fine. How's your pain?
It's much better, thank you.
Okay. Now today, we're going to teach you how to crutch walk. Okay?
Okay.
Now, the first thing we do is to make sure that you know that you're not going to put any weight on that bad leg. Mm-hmm. And I'm going to use this belt to help support you when I get you up.
When people can do some things for themselves but require help with other functions, they require a partly compensatory nursing system. In this nursing system, the nurse assists patients through guidance, support, and teaching.
Not to have to worry about these bandages in the hot summer and stuff, but I think we're still going to be.
Well, I guess there's nothing much I can do about it, but cope with it.
No, I know. In using the self-care deficit theory, when I'm working with my clients, I'm frequently adding and modifying what I've previously assessed in terms of her requisites and the basic conditioning factors. And for example, with my client today, I would be concentrating on those deficits that I had previously identified, which had been in her case, draining ulcers in the elimination area, and as well her need for some assessment in her mobility and safety. And those things are subject to change, of course, so, as I am seeing her daily or another nurse, then we are continually modifying that and giving her guidance and teaching or assisting her with the care of the ulcers. When we're finished, this for the day.
With insulin, might it also be timing be a factor? Could timing be a factor?
That's the way I understand it, yes.
Good. Yes, very definitely. Now, how about activity? Where does activity, some people call
When
this
patients can care for themselves but still need some assistance, they require the supportive educative nursing system. In this nursing system, the nurse assists patients through teaching, support, and by providing a developmental environment.
because there's a lot of myths about lice and they don't want to catch them. So how do you think lice get spread? What's their transmission? How many of you are kind of sitting there going, don't scratch, think of what we're talking about. The self-care deficit nursing theory was used as the model or process to arrive at the teaching plan for the class today. The teacher identified a need in that she needed to teach arthropods to her science class. The arthropods had to have a social or a cost issue involved with them, and the two suggested arthropods were houseflies or head lice. Head lice are a chronic problem everywhere, and the teacher especially remembered this from growing up on the prairies and the problems that she'd had with it. And she came to me because head lice is always seen as a health department or a health issue. The health department would rather not see itself in this light. We see it more as a social issue. This then leads to how can I facilitate students' self-care agency in learning how to care for themselves if they ever encounter head lice. To do that, I agreed to teach the class, and then I had to figure out, okay, how am I going to facilitate their healthcare agency? And that means that I have to look at their knowledge, skills, abilities, and motivation to be able to increase this, so if they ever encounter head lice, they're going to be able to deal with it themselves, or if they're not able to deal with it themselves, at least seek me out so I can point them in the right direction.
A component of self-care deficit nursing theory is the understanding that family members do provide care for infants, children, and dependent adults. And this care may vary in quality and quantity. And the name that has been attached to this form of care is dependent care.
I work with mostly new families, new mothers particularly, so people who are learning how to be parents, and I'm able to assist them at a time when they're developing their own dependent care agency. Here at the drop-in, I use the theory to assess people both individually with their questions and issues that they raise with me, and also as a group. The drop-in, the postnatal drop-in, is a good opportunity for people to learn new skills and gain information from both the nurses that are here and also from each other. And so in that way, it's providing an environment that promotes development. And it also is a really powerful way of women gaining emotional and psychological support from each other and also from the nurses.
Half a cup of food a day?
Well, today we're doing a child health clinic, and I'll be dealing with parents and their young children, and really looking at the dependent care agency of the parents as they deal with the self-care requisites of their children. I'll be mainly using teaching and guiding as my helping methods in helping the parents to increase their skills and knowledge and ability in the care of their children.
The self-care deficit theory can be used with many different cultural groups.
Most of my work with the health department has been with the Vietnamese community, and I've found that the self-care deficit nursing theory has really provided a framework for my nursing actions when I'm involved with my clients. the health department has developed some standard nursing assessment guides, and they've adapted those culturally for the different population groups. And I found that as those have dealt with the basic conditioning factors of the different cultural groups, that's been very useful in my nursing assessments.
A major challenge in implementing theory-based nursing is understanding how a conceptual model or a theory actually works in clinical practice, and how it structures the cognitional work of nurses. Dale Walker, Executive Officer of Nursing with the Vancouver Health Department, and her staff nurses explained why they wanted to implement theory-based nursing and discussed some of the challenges, obstacles, and effective strategies for implementing Orem's self-care deficit theory.
We wanted to implement nursing theory in the Vancouver Health Department in order to make this a satisfying place for nurses to work, a place where they could maximize their skills and abilities in their work with clients. A second reason is, as a nurse administrator, I felt it was my responsibility to help create the systems and the forums in which nurses can practice to the best of their ability, and theory-based nursing seemed to offer a framework within which to do that. Some of the major challenges we faced in implementing self-care deficit nursing theory are the following. Securing an adequate funding base was a challenge at the beginning. Securing the educational resources that we needed was a major challenge. And by that I mean the experts in the local area that we could use as resources, and also the materials that we needed for in-service education. Another challenge was preparing the senior nursing staff of the organization to provide the leadership that would be needed to integrate nursing theory into the fabric of nursing services in the department. Another challenge was dealing with the attitudes of the staff, the fears, the reluctance on the part of some people to engage in a process that they may have seen as primarily an academic type of exercise in the past, and they had difficulty seeing the practical application of it. Time was another major issue, to get time for in-service for a large number of nurses. We had 300 nurses on the staff, and that took a lot of preparation and pre-planning. Another area was the concern from the disciplines other than nursing, who hadn't received the kind of resource support that we had to embark on this major project. And in some cases, the disciplines didn't have as clear a theory base for their practice as we were using.
It would be good too if you set up a session with the prevention.
Some of the additional strategies that worked in implementing the theory were educational strategies. We used one-to-one discussions between supervisors and staff, and we used a series of group education in services for first-line supervisors and for staff involved in the theory. We also used some clinical case conferences where staff who were involved with clients would get together to discuss issues using the theory to guide their practice. We also had some other resources that were helpful in terms of quality assurance. The Quality Assurance Committee really looked at developing the philosophy of nursing based on the theory, and also looked at using a performance review based on concepts in the theory as well. That really helped to build, I think, a commitment to the theory and use within the department.
Using the theory has helped me to work with clients in a couple of ways. Partly, I like to share the assessment tool with them. So when I go in to assess an individual or a family, we will both sit down and look at their universal requisites, their developmental state requisites. And in doing so, we can view what the limitations and their capabilities are. In terms of limitations, of course, it helps us identify what the deficits are, and then how it might be most appropriate for the nurse to intervene and assist them again with their self-care agency. So that's one of the main ways. And I think on a very final note, what the Orem theory helps with is the implementation of a genogram. And although I always did use genograms prior to using the Orem self-care nursing deficit theory, I find I use it even more now. Sometimes at the onset of an interaction, sometimes later. It would depend on the family situation. but by doing so it helps one to see the family in a broader extent, looking at interpersonal skills, problem-solving skills, just to basically conceptualize the family more clearly.
Judith Russo Sebring, Chief of Nursing Service at the Fresno, California Veterans Administration Medical Center, continues the discussion of implementation of theory-based nursing practice.
We decided to implement theory-based nursing practice for two reasons. One was a professional reason and one a more practical reason. We wanted to foster a dynamic nursing environment, and we felt that theory-based nursing was a state-of-the-art and that this would support our goal of a dynamic environment. And then the second reason was a very practical one. We were concerned about our nursing documentation, and we felt that theory-based nursing would provide a structure that would improve our nursing documentation.
To provide for prevention of hazards.
I'm not sure that there are any obstacles that we haven't been able to overcome, but there are some that plague us as we move along. One is the turnover of staff. When I began the project, I was rather naive, and I thought we would have a major focus on education and so forth for a couple years, and we would be well on our way. And what I've learned in hindsight is that there's always turnover of staff, and we're always teaching. So we always have staff in our service at different levels of understanding. Some understand terminology and don't yet understand theory, and then some, of course, have integrated to the point where they understand theory.
And their self-care agency or ability to meet these requisites or demand.
Naturally, it's a difficult process for new nurses to accept a change such as this. One of our challenges has been to make them understand that it can be an easy transition from their old previous place of employment or nursing school to a system such as ours, which uses self-care theory. So what we try to do is be cheerleaders, as well as to introduce to them the practical reasons why this theory will help their job become a little easier. So we try to narrow that theory-practice gap the best we can. This can often be a great challenge.
We followed several strategies in the very beginning. We started with several areas in the hospital where head nurses were interested in piloting the nursing theory. We felt that was certainly the best way to be successful, to start out with people who are interested in piloting. And then we also felt that we had the freedom of not implementing the entire theory. We started out utilizing the universal self-care requisites and the basic conditioning factors only. And then in addition to that, our self-care steering committee, which really planned our various implementation phases, was made up of nurses who are really grassroots nurses and not a top management team. And this made it easier to integrate this pilot and make them acceptable within our nursing staff.
The purpose of this committee is to direct and guide the course of theory application at this medical center. In the beginning, the main purpose of the committee was directed at education and documentation form development. Another activity has been the review of the documentation forms. Presently, we're in our third review of the admission form, which includes the basic conditioning factors and the universal self-care deficits and the health deviation deficit assessment. We are using small task force to look at these individual areas, and they are reporting back to the Self-Care Steering Committee, which is looking at the overall documentation forms.
There have been a number of positive differences that have impacted our service since we implemented self-care nursing. Nursing care has been more of a focus rather than the traditional medical care focus. Nurses throughout our service have a common language that they speak. The standards of nursing care are consistent throughout our service. We have job descriptions that reflect self-care and also our nursing service philosophy statement.
Nurses at Fresno Veterans Administration Medical Center and Vancouver Health Department summarize the benefits of self-care deficit theory-based nursing.
When I first learned the theory, I had a lot of trouble with the terminology and the language itself. I found it was like a foreign language. And it was something that you had to utilize in your practice. You couldn't just read it from a book. You had to actually go and incorporate the whole program and the whole assessments and that into your nursing practice. You just couldn't watch a video or read it from a book.
There has been a unity of nursing at this medical center. Before we started using self-care theory, the specialty groups did their own type of nursing. Now everybody talks the same language. When the med-surg nurse talks to the intensive care nurse or the psych nurse, in the self-care terminology, we know what's going on with the patient and what needs to be looked at, and getting the patient ready for discharge.
I would recommend the self-care deficit nursing theory to other agencies because I think it really does provide direction to nursing practice, and that's very important. I would also like to say, however, that I think an agency undertaking theory-based nursing practice needs to look at all the available theories and really consider which theory fits best with their beliefs and values around nursing and clients, so that process needs to be undertaken initially. However, certainly as a department, I can say that it's been very valuable for us, and I would therefore highly recommend it to other agencies.
Our program evaluation was begun early on in our project. It was a evaluation of nurse attitudes and documentation throughout a period of a year. The findings of that project were very positive. We found that nurses had higher job satisfaction at the end of that year, and we found that nurses perceived the value of patient teaching as more important than they had earlier.
Excellence in action in the use of nursing theory requires time and effort on the part of clinicians and scholars. Nursing should be viewed as a field of knowledge and a field of practice. This demands that nurses continuously contribute to the formation, the validation, and the organization of nursing knowledge, so that there will be a body of nursing knowledge which is contributory to excellence in nursing practice.